So if you use 10 of AI, the machine learning will be disseminated. So for me, my chat GPT model, which is installed on my computer, has learned over about a year or so on which I'm using it, what my preferences are. So you have to use one which is best for you.
Dr. Neeraj, I would like you to demonstrate the voice command.
Yes, I will do so.
Yeah, because the thing is, it will obviate the need of even writing or typing. So that will make it further easy for the practitioners.
And how many of you have used voice command prompt for writing some letter or writing a draft or something on chat GPT? You have used it. So you just tap this button and type it. So I'll see if this works with, hello? Hello? So please write down a thanks message to all the audience which are there and tell them it was a great interaction with them, and we can use AI in healthcare efficiently if we give good prompts to chat GPT, and let's see what future holds for us as medical professional by using AI. I believe the voice was going through my phone, but not through the laptop because it is connected with some wires. Sometimes it happens, but let's see. So I have written this, I have posted the prompt, and now he's writing polite, warm, and future looking. Thank you all delegates for being such a wonderful audience. It was truly a great interaction and engaging exchange of ideas with all of you. Today's discussion reinforced one important message: AI in healthcare can be used efficiently and meaningfully, and when we ask the right question and give the right prompts, especially while using tools like ChatGPT. As medical professionals, we stand an exciting crossroads of medicine and technology. Let's stay curious, responsible, and open-minded, and see what the future holds for us as clinicians with AI as our ally. Thank you. You can stop the sharing. Title slide. I just changed Saraf the presentation.
Thank you, Dr. Neeraj, for such an exciting talk on AI, and I'm sure we'll all go back home and try Dr. Oracle today. So with that, we now proceed to our next session. It is my privilege to invite Dr. Malik sir, who's the Dean of GRIPMER and a visionary academician, architect of structural postgraduate training in our hospital. He will give us deep insight into what goes on and how far we've reached education-wise. Welcome, sir.
Sir, Raji, sir. GRIPMER update 2026?
Yeah.
Huh?
Yes.
Second one, na?
Yeah, that's a GRIPMER update, no? Your phone?
So you're okay with this type of thing?
What? No, give me the
Full?
stuff.
Okay, just this arrows. Huh?
Okay.
Next slide.
A very good morning to you all. I am indeed grateful to the organizers, Dr. Manchanda, Dr. Neeraj, and Veronica, to give me this opportunity and to have me here talk about a subject which is not the key subject for the day, but some kind of a introduction about what we do at Sir Gangaram Hospital when it comes to academics. You all know about Sir Gangaram Hospital, and I bring to you the greetings from Sir Gangaram Hospital. This presentation I prepared essentially for the audience who are not from Gangaram Hospital, just to give them a glimpse of what academics is at Sir Gangaram Hospital and how we have organized it and how things are moving. So, as you all know, and I think we pay tribute to our founder, Sir Gangaram Hospital. He was a civil engineer a philanthropist, and he started a small hospital for a social cause to serve the widows and the orphans. And this was established in Lahore, where he had a number of other buildings which he designed, which he sort of designed for public use, like their GPO and Atchison College. Number of other buildings in Lahore on the Mall Road bear ample testimony to his genius. In view of his recognition, and of course, he turned desert Punjab into a fertile Punjab. In lieu of that, he was rewarded by a large tract of land, which he utilized. The income from that he utilized for all his philanthropic activities. And Sir Gangaram Hospital is part of that philanthropic activity, which has outlived all other things that he had started. At the current time, we are a 737-bedded hospital in the central location, and there are two affiliated hospitals, City Hospital and Colmet Hospital. Overall, we have 33 modern and modular operation theater, 63 ICU beds, and 14 NICU and PICU beds. Just to give you an introduction to the place that we are. So we have recently added a few facilities and expanded our infrastructure. Radiation oncology is the newest kid on the block. State-of-the-art bone marrow transplant unit, PET unit, molecular hematology laboratory, research laboratory, including stem cell research, where we are in the frontiers, and it is headed by Dr. Ganguly, who was the Director General of Health Services, Government of India. And that's where we are doing all kinds of stem cell research, and I'm sure in times to come you will hear more about it. Robotic surgery, and we have 2 surgical robots in our operation theater complex, where our department, general surgery, and other departments like urology, gynecology, they are doing all state-of-the-art robotic surgery. Next-gen genomics is part of our infrastructure, and I think we have more than 1 machines in 2 different locations, and nuclear medicine, which is now state-of-the-art system, where we have the opportunity of treating, not only doing the diagnostic, but also treating conditions which are amenable to be treated by nuclear medicine or nuclear pharmaceuticals. Now, what is this Gangaram Institute of Postgraduate Medical Education and Research? Now, this is our academic wing, you can call it. It is a body which has overarching influence over the academics and research that we have at Sir Gangaram Hospital. We started this DNB program in the year in 1984, and this academic body, which was consolidated in 2012, so that all activities are under one particular umbrella. We give faculty designation to our members based on the NMC, or National Medical Commission guidelines. We coordinate the research projects which are being funded by external agencies like ICMR, DBT, and WHO, DST, and Ministry of Environment. We also run GRIPMA local fellowship in specialized and sub-specialized areas, and herein we get the applicants from national and international areas. Now I'll just give you a little update about what we are all doing. That is the core for our work today. Our functions are academics, and we always make sure that we excel there. And one of the testimony to excellence in academics is that our postgraduate thesis, which are submitted after completion of the course, are returned with commendation. At least 10 to 15% of our theses are returned with commendation by the external evaluators of our thesis project. That's the kind of excellence that we aim for. All our protocols which are submitted are accepted, and none of our theses has ever come back under the title of rejection. We conduct CME and different location, orbit, that is outreach program of Sir Gangaram Hospital. That's also part and parcel of our ambit here. And this CME also is, in a way, our, should I say, inspiration that we have over the years taken part in these CMEs and always try to involve people from outside so that, our outreach into the society and getting people to know about what we are doing becomes more well recognized. We conduct research not only through the postgraduate process, which is of course thesis which all the postgraduates have to do, but in other research projects whichever are submitted either internally or through external help are always vetted through our processes, and that's where we have a major role to play. We are now bringing out a journal which is a regular feature, and I'll come to that in a while. We do guest lectures from experts coming from outside and some experts from India who have big name. And last, I think we had an oration by Dr. Nagi Reddy, who talked about AI and medical practice. And I'm sure Dr. Neeraj's presentation today has taken that process forward. And these are the orations which, not only inspire, but also give us the glimpse into the future. And these are called Gripmer orations, which we hold regularly every year. We ensure compliance. As far as the National Board of Examination is concerned, there are many compliance activities to be done, and all these activities are done through us. And I'll tell you that how these programs have expanded and how this system has now become even more widespread than it used to be. And last but not the least, we create a situation, create ambience in our hospital wherein we bring about bonding between our faculty and residents through programs like sports meet and cultural evening, and also our newsletter, which gives them a 360-degree view about what we are doing at Gangaram Hospital and how to interact better with their own resident colleagues. So these are all the activities, that we are part of, and I'm really happy that administration has given us this responsibility to create something like a medical college environment, and we call ourselves as the AIMS in the private sector, and I'll tell you why. We started off in 1984 with only 5 disciplines. At present, we have 350 DRNV, that is specialized program, that is doctorate of National Board, and DNB, that is Diplomat of National Board, FNB, that is Fellowship of National Board. So these are 3 different programs in the National Board of Examination that we run in 52 disciplines. So I think starting from 5 disciplines and about 20 candidates, we have moved over to 350 residents and 52 disciplines. That is something like it is the largest program anywhere in the country as far as the number of specialties are concerned. We have 19 broad specialties, 23 super specialties, and 10 postdoctoral fellowships. It's the largest program, and we are considered to be the ideal institution as far as running the DNB program is concerned, and that's where I think a comparison with AIMS comes up as far as the number of programs that we have. So these are the areas, where we have the programs, and these are the 10 departments where we have postdoctoral fellowship, overall 52 disciplines and counting. So now we have come out with a comprehensive cancer center that has become the focus of our activities in the last couple of years. And oncology in the forefront, that's, the theme. We have ongoing programs in medical oncology, ped, hemato-oncology, and DNB in nuclear medicine. So in these 4 specialized areas we have, which basically cater to the cancer patients, we have ongoing programs. And as far as the programs in the pipelines are concerned, we have a gynae oncology program coming up, radiation oncology DRNB program in the pipeline, and possibly an FNB program in the colorectal surgery. So with these aspirational 3 programs on the horizon, I think our number will increase to 55 as we enter the next year. So as I was talking about research, I think one of the distinguishing feature of Sir Gangaram Hospital is that we have a great focus on research. And if you were to look at institutions which are doing research, you will find in the private sector, you would, we are proud to say that we are number one. And I'll give you some numbers here. So this is a Scopus Index publication from the time period of 2008 to 2015, and all NMC institution AIMS stands on the top with 11.2% papers coming from All India Institute, and in this MAMC stood at 1.95%. So these are all NMC institutions, and the number of publications were 1,01,034. So when it comes to the private sector, again, they look at 1.06% of all papers, close to about 1,100 papers coming from Sir Gangaram Hospital, and it was only second to L.V. Prasad Eye Institute, Hyderabad. So that's the kind of pride that we have, and that's the kind of literary output into the scientific publications that we have from Sir Gangaram Hospital, and that was the period of 2008 to 2015. Recently, we again looked at the data, and we found that in the period of 2021 to 2025, we had overall 1,183 publications in Scopus indexed database, and overall, we have been having about 350 to about 250, or rather, put it other way, 250 to 350 publications in the Scopus database indexed journals coming out in a yearly basis. So that's the kind of research, and that's the kind of milieu that we have at Sir Gangaram Hospital. And we are coming out with this academic report which will highlight it further, what are the areas which we are focusing upon. And we are indeed proud of this fact that being number one, and I think these last 5 years, no private institution has contributed so many papers to the Scopus indexed papers like we have done in the last 5 years. So we have, again, a very well appointed library. A lot of material is available, and this library is open throughout the 24 hours when the exams are taking place. Otherwise, it's also open till about 10 o'clock every evening. We have a huge number of online resources through Clinical Key, up to date and anywhere. And our budget for the library, which is astonishingly high, is about 2 crores, which I think no private institution has that kind of a budget like we have in Gangaram Hospital. Recently, we have come out with GRIPMA Skill Center. We strongly believe that skills, especially in the those situations where some kind of interventions are involved, be it critical care, be it ophthalmology, be it surgery, be it laparoscopy, can be imparted in the setting of skill center, which can be transferred to the operating room. So with this idea, we started off, can I have a couple of minutes more? I'm just at the last slide. Yeah. So we started off with this skill center. We currently have tools for open surgery. We currently have mannequins and dummies, for procedures like tracheostomy and endotracheal intubations. And we have laparoscopic endotrainers. So we believe that our younger generation will have a better learning experience when they are exposed to a skill center where their learning process will become more wholesome and they will be doing a better job. Obviously, our aim is that over time we should become more digitized in as far as skill imparting is concerned. So we have a regular publication from Sir Gangaram Hospital that's called Current Medicine Research and Practice. It is indexed in Embase, it is indexed in DOAJ and Web of Science. It was launched in 2011, and it's coming out regularly without any issue being dropped, and comes out regularly a week in advance of its date of publication, and it comes out every 2 months. And through this presentation, I'll be very happy to invite you to send in your manuscripts for publication to our journal. So with this, thank you very much for giving me an idea, giving me an opportunity to tell you what we are doing at Sir Ganga Ram Hospital as far as academics is concerned. And thank you, Dr. Manchanda, for giving me this opportunity. Yeah.
Thank you, sir. Any questions or any comments from the audience? Thank you so much, sir. Next, we have the man of the hour, Dr. Sanjay Manchanda, sir. Can we have a huge round of applause for the organizing chairperson of this CME? Sir is a consultant in HD at sleep medicine in Sir Ganga Ram Hospital, and today he will be talking about the art of and sound healing, and what are the benefits and how does it really work on different disorders.
Well, good morning, ladies and gentlemen. I welcome you all to this annual CME, the 15th annual CME. We've been holding it for last 17 years, barring the 2 years of COVID that were unfortunate. But we have been trying our best to bring forward the latest technology. This first session, actually, we have done more of a tangential kind of a thing, that it is not pure medicine, which will follow definitely. So this is basically, today I'm going to talk on healing through sound and music. It is primarily because of my love for the music that I have, taken up this topic, and I have, made a music also for insomnia and, the other kind of disorders, which will help the persons mentally, physically, and emotionally. Now, everything in this universe vibrates. The resonance is the frequency at which something naturally oscillates. The universe was created by a big vibration, as we say, the Big Bang Theory, and the sound. Every living system, from cells and organs to tissues, bones, carry their unique tone, together forming a symphony. It is like an orchestra. If it is in sync with each other, you are healthy. But if anything which goes awry in this orchestra, like somebody playing a bad note, then you become a diseased person. So health, in health, every organ vibrates in harmony, like instruments in the orchestra. In disease and trauma, dissonance takes over. And we can correct that with the normal, sounds of the resonance in a lot of people. And this was first, coined by Jonathan Goldman. The thing is, actually, we have an age-old history of music and its healing properties. But today, the scientific elements have joined together so that we can, talk about it in a slightly more scientific or medical way. So the ancient wisdom meets the modern science. It can be found in many spiritual and sacred traditions. The best doctors heal with divine sound, that was published in 3 BC in Ayurveda. Sarva Rog Ka Aukhad Naam, and that was published by Guru Nanak Dev in the Holy Guru Granth Sahib. Every ailment is a musical problem, and cure lies in the musical solution. And this was by Western mystic, and it was published in 18th century. And sound and music for healing, the sound healing is relatively a new modality, though it is an old modality, but in today's perspective, because we want data for everything. Unfortunately, we need data, rather the experiential thing that we should do. The current field of sound healing is enormous, and its scope and virtually encompass all the aspects of auditory phenomena, from music to nature to sound and electronic and vocal sounds. But there are so many ways in which this can be given to the patient. It could be because of music imagery, it could be because of the tapes, it could be with electronic ear, it could be with the harmonics, it could be with the mantric chanting. So guess the greatest instrument that you have for healing, one that is naturally, that is cost effective, does not require any batteries and electrical outlets, and that is the human voice. How many times it has happened to us that somebody on a telephone talks to you and you feel that noise is not just gelling with you and you don't want to talk to that person. But there is another part of the spectrum where you hear a voice and you would like to communicate with the person because the vibrations are matching, the frequencies are matching. So sound healing aligns the body's energy center, that is the chakras, through vibrations, now recognized as a form of energy medicine, reduces the anxiety, pain, and improves the quality of the sleep. Well, the history dates back to prehistoric times when shaman chanting was there. Ancient schools of Egypt, India, Greece, and other centers of knowledge, they have used sound and music for the healing and were highly developed at that time and even today. The sonic vibrations were known to be fundamental creative force in this universe. So as far as the Vedic civilization is concerned, the oldest in the history of the mankind, so is the classical Indian music, and we have the effects that transgress into the different things, and they can be for the type of the day, the seasons, the feelings, the mood, and the timing. So we have ragas for everything, and if we pertain to them or if we listen to them at the same time, we have got a much better effect. So in modern times, Hans Jenny demonstrated how various substances in plastics, liquids, and sand would take different shapes in the form of life, that is, starfish, human cells, microscopic life, depending upon the different frequencies they were subjected to, and thus showing the ability of the sound to affect the change in the molecular structure. And since the body's 75% is water, it is easy to understand that how sound can create changes in the body. Well, some important people who have contributed to this field in last around 100 and 150 years: Peter Guy Manners from England, Alfred A. Tomatis from France, Robert Monroe. The thing is, he discovered how to use the sound waves to synchronize the hemispheres of the brain and cause accelerated consciousness. Now, do sound and music work? The basic principle is resonance, as I've already told. It is possible to use the sound to project the correct resonant frequency so that the body part causing it to return to its normal frequency, and this is done through electronic instrumentation or human voice. Well, do all the people vibrate at the same frequency? No, because that is where interpersonal relationships generate. If you are having the same kind of vibes, same kind of, frequencies, you try to gel with those people a lot more than the other people. Even though they might not have done any harm to you, but you do not like to communicate. So since the sound can potentially rearrange molecular structure, the possible healing applications of sound are limitless. But there is a flip side to the story as well, and it is conceivable that a person receiving sound from instrument may not resonate with that at a particular frequency, and it could be counterproductive. The least invasive, of course, is the human voice, as I've already told. Now, the role of chanting. What we do is, when we chant together, there is an area of influence which is created around us. Like if you throw a pebble into a pond, the waves will form and they will reach the periphery. You may not be able to see them. But bigger the rock, larger the waves, and you can see them. So larger the area of influence. I'll just tell you a very important experiment that has gone. The therapeutic effects of meditation relaxation, they include lower heart rate, respiration, brain waves, activity, which seems to alleviate many different medical problems and can improve the immunological systems. Now, what is the difference in the sounds that make healthy and that can distress us? I'll just tell you. Yeah, I'm just getting it. It's just stuck a bit. Well, the thing is, have you ever thought why all the sacred names, they start with vowels? Whether it is Om, whether it is Allah, whether it is Amen, it is for the simple reason they generate a vibration which is a self-healing kind of a vibration. And the results of Om chanting has been demonstrated in Harvard and many other institutions to see the drop in the blood pressure, the calmness of the mind, and the better productivity of the person. So it is based on the vowel sounds, and I'll just explain you the experiment very importantly. The first effects of the mass meditation and the prayer, they became noticeable when the number of people participating in an event was greater than 1% of the total population. And this experiment was done by Greg Braden in United States, and he repeated this thrice in a crime-prone state, accident-prone state. And during the chanting, it was found the number of those events, they decreased dramatically all the 3 times. So the thing is, yes, they have. That is why we have the Buddhist chanting and the other kind of chanting, and which help the area to heal. It is not just one person. It is the complete area surrounding you may heal. Now, as far as sound is the heart rate, breathing, intensive care surroundings, communication problems, especially autism, because autistic children are much more, say, receptive towards music. Mozart was an autistic child. So the thing is, they are helped a lot when the music is the key. Then psychotherapy, schizophrenia, rehabilitation, dementia, and of course sleep medicine, that is my subject. Now I'll put forward the music to see that what exactly is there. Volume. I think it is a pretty jarring kind of a note. Nobody will be enjoying this kind of a thing. Now moving from... And listen to this one now. It will soothe your nerves. It will help you respond better. It will make you feel better. Now this is what is the difference between a frequency which hurts you and a frequency which soothes you. As a person and as a, ardent lover of the music, I created a music with one of the most revered musicians, that is Ustad Zakir Hussain. And I'll show you. The thing is, we used acoustic Indian instruments. The instruments that were used was Tanpura, Ek Tara, Swar Mandal, Manjira, and flow of water. So there were no chantings, only the instrumental music were painted as abstract colors of the vibration. Now, this is what... Now, I'll request all of you to close your eyes, relax your body, put your head a bit down, and just close your eyes, relax your body, relax your shoulders, take normal breathing, no effort in the breathing. Before lifting your heads up, rub your neck and rub your forehead. So the thing is, future directions are that sound therapy has to be personalized. It cannot replace medicine. It can only supplement the medication. Digital therapies are there. Integration with lifestyle medicine should be there. The sound has a measurable biological effect, safe, non-invasive, and powerful complementary therapy. As Nikola Tesla once said, that if you want to find the secrets of the universe, think in terms of energy, vibration, and frequency. Thank you, ladies and gentlemen.
आजो ऊपर ही आजो ऊपर ही आजो
Thank you so much, sir, for such a relaxing session. I think the tone for the day is set. So, any questions anyone has? Okay. So, I have a question for you, sir. Sir, so we spoke about healing through sound. So, sir, is this for patients, specific patients who are suffering from insomnia, or like all of us can use it?
The patients of insomnia, we have done 250 cases on that. And the thing is, the results were there, and we did a polysomnography, that is a sleep study in all of those patients, along with the music and without the music. And certainly the efficiency as well as the quality of sleep improved. The deep sleep improved, and the thing is, the patients did feel better. Apart from that, there are specific ailments like autism. In children, it is something which is going to give a lot of benefit, and we have received it. And this CD which we have developed, actually I have not gone public with this thing for the simple reason I take it as a therapeutic tool and not as a selling tool.
Yes, yes, ma'am.
Pardon? I just couldn't. The frequencies are something which is purely individualistic, and that is why I said that you have to tailor make certain things. And for that you need a very, very in-depth knowledge. I do not have that. I have to use other people to develop that. But the thing is, there are equipments today which can give you the feel of those frequencies, like Tanpura. There is electronic Tanpura also to match your scale, to match your singing. So the thing is, the same thing is there with the frequencies of the sounds which are there, and we can use them and we can try them on individuals, the person who will feel better with a particular thing. Because we can't face rejection is there. As I told, that there's a flip side to the story as well. So we have to take care of that part. It is total sleep architecture. Total sleep architecture. If there is properly an increase in the slow wave sleep, or what we call as the deep part of the sleep, because that is the area where maximum amount of, say, immunologically we become stronger, our connections are met with. If the REM sleep is there, it helps you, say, maintain your this thing, memory consolidation is there. So we have to use a lot of things, and it needs a lot of workout right now also. It is not something which is very common, but definitely the benefit is there.
Thank you, everyone. Now we'll move on to the next session. For this, I want to invite Dr. B.B. Agarwal, sir, who's the head of the Department General and Laparoscopic Surgery, Sir Gangaram Hospital. So he'd be talking about lesson learned from Bhagavad Gita, and we're really looking forward to this very exciting session. Welcome, sir.
Good morning, everybody. Thank you for coming here. Greetings from our institution, and thank you for blessings of seniors present, Dr. Malik, Dr. Richa Devan, and many seniors I don't know as yet. Dr. Manchanda set the stage for my talk. I think 3M, M for Manchanda, second M for music, third for music for mind. And thank you very much. Today's, I think CME is a multivitamin nutrition of academics. I say MVN, because 3 letters, M for Manchanda, V for Veronica, N for Neeraj. Thank you very much. So I'll be speaking mostly citing references from other than mine, but we have done all scientific studies on what I'll be speaking. So lessons learned from Gita. I was surprised when Dr. Manchanda asked me to talk about it. I think it was following my 2.5 hour oration at a Kurukshetra University at Gita Mahotsav. So I request you all that our basic teaching is this shloka, Om Sehna Vaptu Sehnau Bhunaktu Se Virya Karvavahe Tejasvi Nam Didamastu Vidvivashamahe Om Shanti. It means all intelligent minds should sit together, nourish themselves together without any conflicts, fights. There may be opposing views, but we can learn from everybody and we go enriched from everybody else. Gita inspired Einstein, Tesla, everybody, all the scientists. Oppenheimer is famous after explosion of nuclear bomb. Another intellectual, Aldous Huxley, wondered, has the medical science helped in health? He said, modern science has made so much of progress that hardly any human being is healthy now. So what is lacking? Since the topic is Gita, as we know, Gita was, Mahabharata was told to Parikshit by Shuk Maharaj. And Shuk is also famous for what we call as his conversation with Apsara Rambha. So again, for scientifically minded people, that हम जितनी conferences में जाते हैं, तीर्थ निर्मलम ब्रह्म वृंदनम, वहाँ बड़े बड़े ज्ञानियों का समूह होता है, intellectuals का, और वो सारे ज्ञानी चिंतन और अनुवाद करते हैं, लेकिन हमें वादे वादे जायते तत्व बोधा, हम एक दूसरे से बात करके बिना ईर्ष्या के कुछ तत्व का ज्ञान प्राप्त करते हैं, और उस ज्ञान से हमें चंद्रचूड़ यानी कि शिव आदि महादेव का ज्ञान जो अल्टीमेट ट्रूथ है वो प्राप्त होता है. As of today we know Gita from Krishna to Arjun, but it was told to father of Surya, Vivasna, then passed on to Manu, Manu passed on to Ikshvaku, then down the Ikshvaku dynasty, it disappeared in Treta Yuga, and Krishna was there to recite it again. So what is it? It is a conversation when Arjun is feeling helpless, fearful. So scientifically, since we are all scientists, what is happening? एक छिपकली का दिमाग, रेप्टिलियन ब्रेन, जो लिम्बिक नर्वस सिस्टम हमें पढ़ाया जाता है, कि जिसके लिए हम खाना पीना, सेक्स, सर्वाइवल और अपने ज़रूरतों के लिए ही लगे रहते हैं, तो उससे हमें डर होता है. डर से क्या? फियर, फ्लाइट एंड फाइट रिएक्शन, कैटेकोलामीन्स कानिन. सो एड्रेनालिन इज जनरेटेड. Entire science of healing is nothing but minimizing your adrenergic responses, converting adrenaline to dopamine and to serotonin. This is what Krishna did to Arjun, converted his adrenaline surge to pleasure, chit anand, happiness, satisfaction, confidence. So it's a timeless science, as Einstein said, nothing new. It has 700 shlokas, of which 85 are questions by Arjun. And all questions by Arjun are repetitive, full of fear, doubt, arrogance. So what does Gita say? There is a triangle of our thought process. We call it Trigunatmak Nishchay. So उसमें मन, बुद्धि, अहंकार. तो अर्जुन को क्या हो रहा है? वो डरा हुआ है. उसके अंदर डर है, क्या अगर मैं हार गया तो क्या होगा? मैं अपने भाइयों को क्यों मारूं? उसकी बुद्धि संकुचित है. वो देख नहीं रहा कि ये लड़ाई क्यों हो रही है, ये युद्ध क्यों हो रहा है. और उसको अहंकार है कि मैं तो आज तक किसी से हारा नहीं, अगर मैं अब हार गया तो क्या होगा. ऐसे में ये सारा हमारे साइंटिफिकली कैसे करता है. सो when we developed a technique for laparoscopic gallbladder surgery, hernia surgery, which became international guidelines, I was invited to write editorial for the topmost journal. This is surgical endoscopy. So I had mentioned, this was in 2008, that whatever I have learned from study of Upanishads and Gita. It was mentioned in this editorial, published in an American journal. So I said a scientist, whether surgeon or physician, should respect the ancient wisdom and culture. हमारी पढ़ाई लिखाई में हमने क्या देखा मौलाना आजाद से और आज तक, कि हम पुरानी बातों को क्वेश्चन नहीं करते, उनको नेगेट करते हैं कि ये गलत है, घी खाना गलत है, रिफाइंड ऑयल खाओ. वापस अब साइंस, फ्रेमिंगम स्टडी जो 48 में शुरू हुई थी, जिसने फैट्स को आउट कर दिया, अब वो कह रही है कार्बोहाइड्रेट को आउट करो, फैट को लाओ और घी को लाओ. सो हमें कभी भी अपनी पुरानी चीज़ों को नहीं नेगेट करना चाहिए, क्वेश्चन करना चाहिए, मॉडर्न मेथड से उसे स्टडी करना चाहिए. सो फॉर दिस एडिटोरियल आई कॉइंड वर्ड इमेजिनियर, imagination driven engineer for doctors. So doctors should be innovative, he should understand body at molecular level, he should respect ancient wisdom, he should know anatomy, embryology, genetics, he should be well versed with the modern technology, and he should not be afraid of taking up things which are coming like machine learning, as Neeraj told us, and robotics, etc. So Arjun was suffering from this self-doubt, fear of defeat, and fear of his own limitations. So this triangle of our decision making is akin to clinical decision making. If we take care of this triangle, our clinical decision making will be very simple. As long as our decisions are not affected by arrogance, anger, and greed. So मन बुद्धि अहंकार अगर ठीक होंगे तो हमें कोई चिंता नहीं होगी. जैसे कि वेस्टर्न साइंस में प्लेटो को कोट करते हैं कि डॉक्टर नोज व्हाट इज़ राइट फॉर द पेशेंट, उसको कुछ बताने की ज़रूरत नहीं है. तो हमारी गीता में तो ये पहले से ही लिखा हुआ है कि अंतरात्मा जो है वो परमात्मा से जुड़ी हुई है और हर मनुष्य परमात्मा का अंश है. तो सही और गलत का निर्णय लेने में अगर हम अंतरात्मा की आवाज़ सुनेंगे तो हम कभी गलती नहीं करेंगे. सो मॉडर्न साइंस कॉल दिस एज द लिम्बिक सिस्टम, छिपकली का दिमाग, कि हम अपनी बेसिक नीड्स पे ही लगे रहते हैं और हम उससे आगे जाते नहीं हैं. साइंस बिहाइंड गीता, अभिमन्यु का हम सब जानते हैं. अभी लास्ट 2 months बैक there is a study published in this high impact journal which says during fetus development hearing mechanism is the initial one to develop. 10 minutes over, so I have not started. So these are the Gita shloks pertaining to health. We know health is प्रो इन्फ्लेमेटरी साइटोकाइन ज़्यादा होते हैं, एंटी इन्फ्लेमेटरी कम होते हैं तो हम बीमार होते हैं, एंटी इन्फ्लेमेटरी ज़्यादा हो तो हम हील होते हैं. और इन इम्यूनिटी और इम्यूनोसप्रेशन में इनडायरेक्ट रिलेशनशिप है. और हमारे साइटोकाइन या तो बैक्टीरिया के इंसल्ट से बनते हैं या हमारी सोच, डेंजर एसोसिएटेड मॉलिक्यूलर पैटर्न्स भी होते हैं जो साइटोकाइंस को ड्राइव करते हैं. और हमारा जो वातावरण है वो होस्ट, पैथोजन और ये वाला ट्रायंगल नहीं है, एपिडेमियोलॉजिकल ट्रायड, बट आई सेड इट इज़ ए क्वाड. The fourth dimension is the environment which we carry outside and inside body. We call it microbiome. And 1% of our cells are, 10% of our cells are human cells and 90% are microbiome. DNA and RNA, 1% is human, 99% is microbiome. So they all are working to make our body healthy. So we wrote an editorial in which said we should forget epidemiological triad, we should be talking about the quad. We call it microbiome. We studied that the gut microbiome and skin microbiome helps in skin healing after surgery and convalescence from surgery. There is level 1 evidence which shows that infections are less, paralytic ileus is less, pain requirement is less, infections are less, antibiotic requirements are less, and surgical site infections are less if our microbiome on the skin is healthy. So we conducted a study and published that सर्जरी से पहले आप दही से नहाकर आते हो तो आपको वो इन्फेक्शंस कम होंगे, जो गीता में एक श्लोक से आता है जो आप पढ़ सकते हैं, यहाँ लिखा है. इसी तरह गीता योगा पे जोर देती है. योगा में क्या है? चित्तवृत्ति निरोधा योगा, स्थिर सुखम आसनम. मतलब आपका मन और शरीर में कोई विरोध नहीं होना चाहिए और वो वाली एक्सरसाइज करनी है, स्थिर सुखम आसनम, जिसमें आपको कष्ट की अनुभूति ना हो और आप आराम से उस पोज में कुछ समय रह सकें. और ये इसमें साइंस क्या कहती है, डॉक्टर मनचंदा ने कहा हमारे ब्रेन में 95% मेटाबॉलिज्म हैपन्स इन एन एरिया जिसे हम कहते हैं शैतान का दिमाग, इंग्लिश में कहते हैं डिफ़ॉल्ट मोड नेटवर्क. जो काम करने वाला दिमाग है वो 5% मेटाबॉलिज्म यूज़ करता है ऑन फंक्शनल MRI PET स्कैन्स. दीज स्टडीज आर ऑन बेस्ड ऑन फंक्शनल MRI PET स्कैन्स. सो ये जो डिफ़ॉल्ट मोड नेटवर्क है, अगर ये शांत हो जाए तो हमारी आउटपुट, जिसे हम पॉजिटिव डायमेट्रिक एक्टिविटी कहते हैं, ये बढ़ जाती है. तो काम का तो 5% है, हमें 95% को कम करना है, 5 को बढ़ाना नहीं है. तो ये वेस्टर्न स्टडीज़ हैं जिसमें देखा गया कि मेडिटेशन एंड म्यूज़िक, वेदर एक्सटर्नल इम्पल्स दैट इज़ म्यूज़िक और इंटरनल मेडिटेशन, दोनों से ही ये पॉजिटिव डायमेट्रिक एक्टिविटी बहुत ज़्यादा बढ़ जाती है और इम्यून रिएक्शंस कम हो जाते हैं. डॉक्टर मनचंदा ने स्लीप की बात की, सर्केडियन बायोलॉजी, दीज. सो एवरी सेल, आई थिंक आई विल स्टॉप हियर. Basically, Gita teaches us about a lot of things, and adopting a sattvic way of life helps in healing. So we have published on all these things. Thank you very much. These are the molecular things behind breathing, exercise, and all that. India has given a lot more than what West has given to us. This is a summary. This is from Vishnu Puran that Bharat has been defined. People say it's a new concept. These are the things which we gave to the world. And these are publications on haldi, no relation between piles and spices, keeping your knife away from the umbilicus, yoga after post-operative convalescence covered by American media, music published in Journal of American College of Surgeons helps in post-operative healing. So aim is to make the patient healthy in 48 hours. So thank you very much.
Thank you, sir, for this really unique and beautiful lecture. And it's our loss that due to lack of time, we could not hear the whole of it. Any one or two really exciting questions? So now, after these extremely exciting talk, we come on to medicine. And the first... Okay. So in the Hall B, Gulmohar, also the sessions are started. So whichever topic you're most interested in, all of you are welcome to attend that. So for the first session in this hall, I'd like to invite Dr. Neeraj Jain, sir, who's a senior consultant in rheumatology, Gangaram Hospital, and Dr. Richa Diwan, ma'am, who's the head of the department Family Medicine and senior consultant in medicine at Gangaram Hospital. And our speaker, Dr. Sujata ma'am, who is the senior consultant and head in pediatric rheumatology. Today, ma'am will speak on 10 essentials and take-homes of pediatric rheumatology for the pediatrician.
A very warm welcome to everyone for this session. And we have got an first talk on actual medical sciences. We have got Dr. Sujata Shani. She's a pediatric rheumatologist, one of the few in her specialty, very few pediatric rheumatologists we have in our country. And she's going to talk about 10 essentials of pediatric rheumatology for the practitioner. And you know that rheumatic diseases are a bit difficult to diagnose in children because symptoms are vague, they're unable to express, and there are not too many diagnostic tests available. So let's learn from the master, Dr. Sujata.
Thank you so much, and good morning, everybody. It's a cold, wintry morning, and it's heartening to see so many in the hall this morning. So who are pediatric rheumatologists? So pediatric rheumatologists are really musculoskeletal specialists who look after a wide variety of diseases. In addition to childhood arthritis, we look after several connective tissue diseases. Prototype is lupus. We look after vasculitis, commonest Henoch-Schönlein purpura. We look after many autoinflammatory diseases that many of you may not be familiar with. Many children with overuse disorders of the bones come to us. We have children who have psychosomatic disorders and come to us with chronic pain. We can also help you to diagnose several heritable disorders of the connective tissue, and then we can help you to identify patients who have musculoskeletal complaints that belong to many specialties. So we diagnose children with leukemias, storage disorders, tuberculosis, to name a few. Of course, the longer the fever, the less is the likelihood of the having a infection etiology. Practitioner point of view, most important thing that I understand is the concept of window of opportunity. So in rheumatic organs involved, we understand the concept of disease, activity, and damage. So it's very important to pick up these children early on in do not have any damage. And therein comes your role where you can identify a patient appropriate team so that we have the best possible outcome. When you look at laboratory in pediatric, again, essential to understand what is the pre-test probability of ordering in living clinic. 50 sitting here, you might have 50 here. Does is being because the specificity for any is, and you must think what test I order for this patient in the clinical context. So choose right test for the right patient at the method, and very important is choose the right laboratory that you know is going to run this test. So if you ask for tests, you often run into trouble because something will come positive. So we often have patients who come to us with families which are very young. Child has swollen joint, and the family says the factor is negative. But then the rheumatoid factor is negative in 95 with juveniles. No, it's very important from the practitioner. Biologic modifiers. These are becoming particular biologic immune targeted, and in the world 7 out of 10 children are on biologics. So you need to know when a biologic febrile, how are you going to manage that? Are you going to screen for infections that should come positive? So if I have a Still's disease who's on a biologic medication called tocilizumab or Atembra, and that patient has, you may find that C-reactive protein is negative. So initial point of contact with the child and family, you have to be aware about the use of biologics. Our own center, 4 out of 10 children with juvenile arthritis are currently on biologics. When it comes to childhood lupus, connective tissue disease management has changed dramatically. From patients with a lot of severe immunosuppression, there are now many designer drugs available, low effect profile, and excellent outcome. Regrettably, we don't have drugs in our country. We don't have access to drugs such as Belimumab, anifrolumab, which is voclosporin, but they'll come. Again, we need to be aware that we must use steroids for the shortest possible period. So treating pediatric diseases is not good in case open-ended steroids and vasculitis. That's called Kawasaki disease. Treatments are now with early use intrapatients very good. Out of note, child was a very morphology of the vessel. These children miss any lesion. That is 2D. Ourselves national guidelines that come every year for these. A very important thing. Children who progress to adulthood with them. And therefore, care, we need to develop a transition program for these patients. We are very lucky to have a very vibrant hospital and transition our patients for adults. And the advantages that we can initially offer, and the child and family don't feel abandoned, move on to the adult models of care. So that's very important. We need to focus on transition for children with disease as they become older. What about imaging? There's been a big advance for the use of POCUS, that is point of care ultrasound in practice. And we're so happy to tell you that we are one of the few units in the country where we use the ultrasound machine for scanning for the joints of the children. Is this important? Because the ultrasound is very sensitive to pick up a joint disease that our hands may miss. It can tell us how much of synovial proliferation is there versus fluid. It can guide us with disease activity because we can study the power Doppler. And also it's very important to do accurate intervention when we want to inject these patients. So POCUS has become a big part of pediatric rheumatic diseases. So we are aware of patients who have autoimmune disease such as lupus, but there's a whole genre of diseases where the innate immune system is abnormal, and these are called autoinflammatory conditions. They are becoming more diagnosed in our country now, and that's because of availability of whole exome sequencing, and there are targeted therapies available for these patients. And finally, it's very important for us not to only do a clinical care for the child, but take into consideration the child and the family's perception of disease. And this is called PROM, that is patient reported outcome measure, and it's part and parcel of our day-to-day practice where we want to look at what the patient feels about their disease activity. And we don't willy-nilly treat patients. We treat the patients to particular targets. We define what is called remission for each disease, and then we calculate certain markers, such as in a child with lupus, we look at what is called SLEDAI. In myositis, we do CMAS, and so on and so forth. So I hope I've been able to convince you that pediatric rheumatologists are pattern recognizers. We can help you with differential diagnosis of children who have many, many MSK complaints. We have to evaluate these children carefully with few laboratory tests and treat them appropriately. We must talk to every child and family and look at patient-reported outcomes and objective assessment, appropriate management, individual child, and then transition as required are all pillars of good care for children with rheumatic diseases. So thank you very much.
Thank you, Dr. Sujata. I think really the 10 minutes were a little short for you. So we'll someday have a full day CME for you. I think we can invite one or two quick questions.
JAK inhibitors in rheumatic diseases.
Yes, JAK inhibitors are licensed for use. Currently, they are licensed in several subcategories of juvenile arthritis. And we have enough data on a drug called tofacitinib. As far as the other JAK-STAT inhibitor, that is baricitinib, is concerned, the trial work is still going on for resistant uveitis for patients who have failed anti-TNF.
Dr. Sujata, I will just ask one question for the audience actually. So what are in a patient, a child with PU, what are the clinical signs when they should ideally refer to a rheumatology opinion actually, a pediatric rheumatology opinion?
So again, it's a question of examining the child very carefully. So if a child with prolonged pyrexia has got photosensitive rashes, has got skin vasculitis, has got asymmetric pulses, is hypertensive, has features of multi-system disorder, and where your patient has failed an adequate course of antibiotics, screening for tuberculosis is negative, you must think of rheumatology, because the longer the fever, the less the chance of infection.
Thank you so much. Thank you, Dr. Sujata. I think we'll close this session.
Thank you, ma'am. I request the chairpersons to kindly be seated for the next session. And I'd like to also invite Dr. Satish Saluja, sir, who's the Vice Dean of Gripmer and the Head of Neonatology at Sir Gangaram Hospital, and Dr. Anil Sachdev, sir, who's the Head of Pediatrics at Sir Gangaram Hospital. Chairpersons to please invite the next speaker. Dr. Pankaj Garg, sir.
Good morning, all of you. It's my pleasant duty to invite Dr. Pankaj Garg, who is Senior Consultant in Neonatology at Sir Gangaram Hospital and the Vice Chairperson in the department. I think and he's going to speak on a very vital subject, on very vital individuals, vulnerable individuals, our tiny premature neonates. So what he's going to speak about is on smartly managing extremely premature neonates for intact survival. Pankaj.
Good morning. Thank you, Dr. Saluja and Dr. Anil. So my topic is to discuss what we have done in our hospital to smartly manage extremely preterm babies for intact survival. Before I do that, two terminologies needs to be explained further. Extremely preterm babies are babies who are less than 28 weeks of gestation, and roughly you can say babies are less than 1 kg. And intact survival means that they not only survive, but they survive without severe intraventricular hemorrhage, bronchopulmonary dysplasia, which is a condition of lung when they are not able to come out of ventilator, cerebral palsy, which is a very debilitating condition, cognitive deficits like autism, ADHD, and others, and necrotizing enterocolitis. And neonatologists are those people who are specialized after doing pediatrics to take care of these babies. Now, all of us know that babies are being survived all over the world. This photograph is of a smallest ever baby born in the world who has survived 268 grams in Tokyo. Now, this is not something which is happening only in Japan or in Western countries. We are also able to match that type of survival. Even if you look at the lowest line, 500 to 750 grams, we are able to save around 50% or more of these babies. And what is also important is to know the gestations. Even at lower gestations and weight, babies are being survived today. The issue is whether we should be able to save them with intact survival. This is a baby who was 520 grams, stayed in our hospital for a long period of time. Now this photograph is 1.5 years, 5 years, and then 8 years, and the baby is going to normal school and doing well. what can we do so that these stories are repeated? We have to start from the preconception time. The mother also have to enter the pregnancy at the right age, vaccinated against rubella, chickenpox, no alcohol smoking in pregnancy, folic acid, which is now called periconceptional tablet, 0.4 milligram per day, should enter pregnancy when the serum ferritin levels are optimum, iodine is optimum, and very important recent addition is DHA. DHA, deoxyhexaenoic acid of 200 milligram per day. If it is given in the pregnancy, not only the premature babies are born less, they are born with better IQ potentials. Now, second point is place of delivery. I think it is very important that preterm babies may be born any point of time, and there are a lot of units all around the country and in Delhi where preterm babies are born. But if the preterm baby is born, which is less than 28 weeks, it is best to be born in a center who specialize in taking care of these babies. And this is not what I am saying. There is data to suggest that very small babies, if they are born somewhere else and transported to other center, there are more chances of IVH, there are more chances of complications, and more chances of mortality. So place of delivery matters for all, but especially for these group of babies when they should be born at a lesser gestation. Third option is to give these expected preterm mothers a dose of steroid. Here we are talking about dexamethasone, which is given to expectant preterm babies between 24 weeks and 34 weeks, 4 doses, 6 milligram, 12 hours apart. It has been shown that dexamethasone, which is such a low-cost strategy, helps them to have better lungs, their HMDs are lesser, their IVH, intraventricular hemorrhage, is lesser, and this is something which government has allowed even the ANMs to use at the time of referral. Fourth strategy is to use magnesium sulfate. Magnesium sulfate was being used by obstetricians in pre-eclampsia or threatening eclampsia, but now we want to use it for expectant preterm babies, especially babies who are expected to be delivered less than 32 weeks. Loading dose of 4 to 6 grams and then per hour 1 gram. And this short dose of 24 hours does not have any maternal side effects, but have benefit effect that if you give it to 25 these babies of less than 32 weeks, one cerebral palsy can be saved. Very low cost strategy to prevent preterm babies cerebral palsy. Delivery room management is an extensively important part of care of these babies, and one should be trained to take care of these babies. There are protocols that how to maintain temperature of these babies. We have special heated mattresses, plastic wraps, so that babies, as soon as they are born, they're kept in the plastic wrap, not even wiped. We do everything within the plastic wrap, which takes care of their temperature. And the babies reach in the NICU at a normal temperature, their chances of survival are better, their cognition is better. Very important strategy, which is very, very low cost strategy, is delayed cord clamping. What do you mean by that? There was a time when as soon as the baby was born, the cord were clamped. But now we know that if baby is breathing fine, then you delay the cord clamping at least for 60 seconds. And because the preterm baby may not be able to cry, if baby is not crying also and baby is more than 29 weeks, we do cord milking. That means from the placental end to the baby's end, 4 times we milk the cord so that baby gets extra blood, which has beneficial effects. Unfortunately, less than 29 weeks, this strategy of cord milking may have harmful effects, that it can increase risk of IVH. So less than 29 weeks, cord milking is not recommended. What is instead recommended is intact cord resuscitation. That means at the time of delivery, the baby is still connected to the placenta, and we are resuscitating the baby by the side of the delivery table. 7th strategy is giving CPAP births with neopuff. We all have been using self-inflating bags before, but now we have self-inflating bags have been replaced by neopuff, which is a T-piece resuscitator. And in our hospital, we not only provide T-piece with this, we also have a humidifier attached to it, also have a blender attached to it. So we give measured oxygen, which is humidified oxygen right at birth for these babies. Respiratory distress management has been redefined. We have all the facilities for taking care of these babies, whether it is ECMO, whether it is INO, HFO, and ventilation. Another strategy which is very important is caffeine citrate. Preterm babies are known to forget to breathe. And the remedy lies in this caffeine, which is not the caffeine which we drink. It is a specialized caffeine which is called caffeine citrate, which is a drug of choice for apnea prematurity. And the credit goes to Barbara Smith, who brought this to the world. And now we are using caffeine for these babies to prevent apnea of prematurity and to facilitate extubations. And this is another aspect of DHA. We were part of this study when the role of DHA was defined for the country. And DHA is something which can really make a difference. You can see the photograph on the left side, a baby will see without DHA or DHA deficient baby, and on the right hand side, you can see the clear picture which baby can see baby is sufficient DHA in their body. Ninth strategy is reducing infections. Preterm babies are born, but if they get infection, their morbidity is increasing. Despite increase of healthcare-associated infection all over the world, in our hospital, in our NICU, we have been to show decline in the healthcare-associated infection over last 20 years. The right now rate is only 3% of babies who are born in our hospital. So other is point of care. We have a lot of point of care facilities like flexible bronchoscopy, endoscopy, functional nasal endoscopy, functional echo, point of care ultrasound, point of care sampling, so that baby doesn't have to move from the NICU and remain in a stabilized condition. Very, very important is a Q-based family-centered developmental and supportive care of these preterm babies by stimulation. Simple things like eyes are covered under phototherapy, there are quiet times during each shift, baby is not disturbed, clustering of events, incubators are also covered. We write this, please see and observe me, but don't touch me if possible. Nesting of babies in incubator, which is being taught to all the mothers and all the parents in the NICU. Co-bedding of twins, this humanized care is making a lot of difference, reduction of sounds, reduction of light to these babies. We know that too little stimulation is bad, and we are making sure that we are giving appropriate stimulation to these babies. Parental involvement is of paramount importance in cognitive improvement of these babies, whether it is kangaroo mother care, which we start right at birth, but there are specialized models also like COPE, creating opportunity for parent empowerment, Premise Start program and H-Hope program, when we train the parents to train inside the hospital so that once they go home, they're able to continue that type of optimum stimulation for these babies. So my key message is for smart survival of preterm babies is that we take care of their expectant mothers antenatally, in utero referral of expected preterm births, antenatal steroids and Maxelf, delayed cord clamping, respiratory distress management by surfactant and caffeine, optimized parental and enteral nutrition, better infection control strategies, supportive and parents' participation, and excellent follow-up program. So I'm not put
We'll give later on. So there are no questions. I think the one
the next doctor in rheumatology. My privilege to be in his session, and he will be speaking on a eyes, dryness.
So just thank you.
Two pediatric lectures. We get of eyes and mouth from fissuring of the head and get it is a system of 9 to 1. We choose because we know it is kind of diseases such as diabetes disease. So have extra gland say SSB. So we have burdensome as an overlap with this. So one is a 3-year-old woman who came with onset acid severely and had an assessment had the secondary Sjogren's. In the kidney patients and the area that interstitial nephritis, however, we see in clinical practice, we see more of renal tubular acidosis present case that I've just shown. A skin biopsy showed reduced intraepidermal nerve fiber density with a positive SSA. This is a small fiber neuropathy which is associated with Sjogren's disease, which we must always remember. Just don't pass on pains, aches, pains, and nerve symptoms as maybe non-specific. So this can occur in about 10 to 20% of patients. The clues are aseptic meningitis, multiple sclerosis type, or even an NMO that I've shown. Small fiber sensory neuropathy is the most common. We do hypertension might help. Most of the axonal myopathy. The affected GI would be in the form of reflux disease and atrophic gastritis. Don't forget patients who got persistent amyloid alkaline phosphate are probably having an primary cirrhosis or what is known as cholangitis now, or an autoimmune hepatitis. Finally, red flag. We know that Sjogren's is the most common autoimmune disease-associated lymphoproliferative disorder. Rest could be 5 to 10%. Increases relation of the disease. The most common is what is known as a marginal lymphoma. The others come in this. And what are the clues to it? A persistent lymph node enlargement, persistent intractable, low complement going down over a period of time, or a kind of a monoglomal gammopathy. This should make one think that this patient could be having an underlying lymphoma. What are the specific investigations in a patient? ANM is 90%, forget not in 100%, 90%, and then say RO, which is quite specific for this, of course, can occur in other CTDs also. Feature in 60 to 80%. Rheumatoid factor can be present in up to 50% of patients. And of course, objective assessment of eyes and mouth by these tests that we do. Sherman is a very simple test, and an oral salivary gland, unstimulated salivary flow rate. Those cases you are not very sure. You can do a very simple lower lip biopsy, which can dense lymphocytic infiltration is calculated by what is known as a focus score. Salivary gland ultrasound is an upcoming non-invasive, very important, which will help diagnosing, managing, and prognosticating of Sjogren's by two important parameters: inhomogeneity or in adequate areas. The higher the grading, the more the chances of systemic involvement, as well as probability of a lymphoma down the line. This is the classification that is used in studies. However, as in our practice, simple things like excessive dryness of eyes, mouth, presence of an SSA and antibody, presence of systemic features, which would probably go along with Sjogren's, like I've just described, would help more than these kind of classification criteria, which are used to classify, not diagnose. Finally, coming on to a brief overview of the treatment as per the latest guidelines. If, as far as the eyes and the mouth are concerned, local steroids, topical cyclosporin, using sugar-free gums. Pilocarpine helps certainly in patients with dry mouth. If you got involvement of the joints, NSAIDs don't work that well for a long period of time. You have to go on to some disease-modifying drug, of which hydroxychloroquine is the best drug. Cutaneous involvement, topical steroids, of course, don't help so much. Systemic steroids, along with steroid-sparing drugs. And then going on to the rest of the systems where you need more aggressive treatments. Maybe you could start with drugs such as mycophenolate oblique azathioprine, going on to cyclophosphamide rituximab. In more recalcitrant diseases, IVIG, especially in the central nervous system or the peripheral nervous system involvement. And in very rare conditions, you can also offer a plasmapheresis. Having said that, let's go on to an audience poll. I don't know how much you understood. In a middle-aged woman with chronic fatigue, polyarthralgias, with mild dry eyes and mouth, what is the most likely answer when suspecting primary Sjogren's? Please have your voting pads on. Rare disease, severe Zika only. Positive SSA RO in more than 90% of cases. 25 to 40% are seronegative, often requiring specialist input. Extraglandular features are rare in less than 10%. Time begins now. How many seconds, Veronica? Oh. Nobody's answered? Okay.
Voting bad? नहीं, on नहीं हुआ ना उस पे, vote नहीं आया.
Hasn't come, been recorded. You can answer.
Anybody, just raise your hand. Anybody, what's the correct answer? Anybody, please? Okay. So, after this presentation, 25 to 40% of patients may be seronegative, often requiring specialist input. Right? That is the correct answer. So, what is the take-home message? This is early days, I think, as far as voting is concerned. This is a truly systemic autoimmune disease where extraglandular manifestation can be up to 40 to 50%. Don't forget that of these patients, and they often drive presentation as well as prognosis. We should not forget that. Thank you very much. I acknowledge my postgraduate, Dr. Meghna, who's done a great deal in preparing this presentation. Thank you very much.
Thank you, Dr. Dugal. It was an excellent talk. I think what is important to remember is that Sjogren's disease is the new term which is now acceptable. Earlier it was called Sjogren's syndrome, and that has been replaced by the term Sjogren's disease because it's a distinct disease. It's not a cluster of few conditions or symptoms.
And also, it is now differentiated between primary and not secondary. It's called an associated.
Yes.
When you call a primary, it is just a primary shows, and the one that is associated with conditions such as rheumatoid, lupus, etc., is called an associated Sjogren's,
Yes.
not a secondary Sjogren's.
Yes, so that is what is important to remember is that it's Sjogren's disease and it can be associated with other conditions like rheumatoid arthritis or anything else. Thank you, Dr. Nath.
Thank you, chairpersons. Now we move on to the next session on one of the commonest complaints that we all face, reflux. For this session, I'd like to invite our chairpersons, Dr. B.B. Agarwal, sir. He is the head of the Department of General and Laparoscopic Surgery, and Dr. Anil Agarwal, sir, who's the senior consultant in the Department of GI Surgery. Can we please have... To talk, I'd like to invite Dr. Tarun Mittal, sir, who's the Senior Consultant and Unit Head in the Department of General and Laparoscopic Surgery, to speak on the topic Management of Reflux Disease.
BB sir must be outside, yeah. Good morning, everybody.
Sorry for the delay.
Dr. Tarun is a pride for institution and our Department of Laparoscopic Surgery. He is a very curious and innovative surgeon and does the most recent work which becomes a standard for others to follow.
Thank you, sir. I bring greeting from Sir Ganga Hospital. Chalniri. Yeah. So, gastroesophageal reflux disease is a very common problem which each of us face in our OPD, and sometimes we have doubt what is the diagnosis, what investigations are required, whether surgery is good or not. So these all things are there, and because it's a very common problem, and if it is not managed well, it can have a lot of lethal consequences also. So one should know when to refer, when to operate, and very important with this, our current lifestyle, it is increasing, obesity is increasing, so is our gastroesophageal reflux disease. Stress is more, so and lifestyle is changing. A lot of initial early to bed, early to rise concept is not there now. So that way lifestyle management are always sitting on the laptop, which has increased the incidence of gastroesophageal reflux disease. So what is that? It is basically, there is a sphincter and the acid is produced in the stomach and food is there in the stomach. If the sphincter is not working well, or if the more of acid is produced in the stomach, or if the esophageal peristalsis is not good, in all these three conditions, the acid can reflux into the esophagus and cause the symptoms, or the food later on can reflux and cause the symptoms of gastroesophageal reflux disease. So what are the most important symptoms? The most important and the most common is heartburn and food and acid regurgitation. So you will have retrosternal burning and sometime epigastric pain. Sometimes you can have dyspepsia, nausea also, or bloating. Dysphagia is a symptom which can sometimes be alarming, but in hiatus hernia with gastroesophageal reflux disease, you can have a commonly dysphagia as a symptoms. And very important, sometimes these patients have chronic cough, change of voice, if the acid reflux into the larynx or the trachea. So these are called the atypical symptoms, or the dental erosion. So you have to rule out a gastroesophageal reflux disease in a patient who has been recently diagnosed as asthma in a middle age time, or they are having chronic cough which is not getting relieved. So we have to investigate for gastroesophageal reflux disease in these patients. So what is the diagnosis? Most of the time based on clinical symptoms. And if the symptoms are there in your OPD, you will always prescribe them proton pump inhibitors. And the response to suppression is a very important thing, which is if they are having good response to suppression, then it means the diagnosis is same. And also if the patient does not want to have long-term proton pump inhibitors, then they will have good results with surgical management also. Sometimes you require endoscopy if they are not getting relieved with the proton pump inhibitors, or they are having complication like a dysphagia. And sometimes when they have atypical symptoms like chronic cough or change of voice, and your diagnosis is non-erosive, in which you have done the endoscopy and esophagitis is not there, then this role of esophageal pH manometry monitoring comes in which you put a probe in the esophagus and the G junction, and it is monitored for 24 hours. And all the refluxes are monitored through this esophageal pH monitoring. As a routine, it is not required for the diagnosis of gastroesophageal reflux disease. So there can be a lot of complications, like it can be erosive esophagitis. There are grades of esophagitis from A to D. You can have A, B, C, D. C and D are more difficult to manage. They can have stricture. Barrett's esophagus is a condition. It's a metaplasia in which the stomach columnar epithelium goes into the changes in the esophagus area, and it becomes columnar metaplasia. In that, later on, it can convert it into a dysplasia and then the malignancy. So that is a very lethal consequence which can happen if the GRD is not managed well. And these patients can have COPD as told, and dysphagia if they have strictures or they have a large hiatus hernia. So the treatment option, one of the most important thing, we describe all the patients, the proton pump inhibitors, but the most important thing is lifestyle modification. They should have early to bed, early to rise, and then they should have minimum 2 to 3 hours gap between the last meal and when you sleep, and do not drink water with the meals. Avoid the things which trigger GRD, like a very fatty meal or a tea, coffee, juices, and cold drinks, chocolates. These all things should be avoided. And take a lot of probiotics or curd, which is a very good. I myself was suffering from GRD, and after this lifestyle modification, I have stopped using proton pump inhibitors for past 7 years. Initially, I was having for 2 to 3 years continuous. Then, obviously, if these patients are obese, then you would have to manage the weight and control their weight. And if they lose weight, most of the GRD will reduce. And then if these two things plus acid suppression drugs are good, you should prescribe them, but not long-term. If you prescribe long-term PPI, we see, in all our prescription, we write proton pump inhibitors, but they have its own consequences, like B12 malabsorption is there, calcium bone health, calcium absorption is not there, bone health decreases. Then there are side effects, like patient have had CKD also, with if you are having long-term PPIs. So it is not without its side effect. So one should be cautious when you are using acid suppression drug for long-term. And give an option of surgical therapy or an intervention if they are, after they are stopping the drugs, they are again having the GRD. So endoscopy is a very simple procedure which will help us in diagnosis of GRD if there are erosion, and then it can complications. There are like esophagitis, Barrett's, any other disease we are missing. Sometimes vague symptoms of GRD can be so if the relief be PPI, hold endoscopy being disease, which it is a lot of indications. If it's patient choice, patient does not want to lifelong side effect, and it's not responding so well to the medical complication or a